Thank you very much. Thanks for the invitation. So I have 20 minutes to talk about the GIST. So let's get going. We have a lot of stuff to cover. So the obligatory epidemiology slides. So GISTs are truly uncommon. So there are probably about 5,000 to 6,000 new cases in the US per year. And this is clinically significant GISTs. Micro-GISTs are actually much more common. These are GISTs found at autopsies that never become any problem. They can arise anywhere in the GI tract, but most commonly in the stomach, and then in the jejunum, ileum, and the colorectum and duodenum. And the median age at diagnosis is 60 to 65 years. So these are the symptoms. So 2/3 present with symptoms from the GI tract, usually bleeding or obstruction, pain, or perforation. And up to 45% of them have mets at diagnosis, usually to the liver, then peritoneum, omentum, but nodal mets are not really common for GISTs, except for the rare SDH deficient GIST, which we won't talk about that much. So a little bit about pathology. So as you know, GISTs are generally stained very strongly positively for KIT. 95% of cases. For DOG1, they almost all test positive. So these are very useful diagnostic stains, although the histology will probably give it away most of the time. 80% of them are KIT mutated. Those who are KIT wild type tend to be PDGFRA mutated, and those that are neither KIT or PDGFR mutated are called wild type. And they tend to be SDH deficient. So moving on with mutational testing, and this is a recurrent theme that you will see here in a few slides. So I'm definitely a proponent of mutational testing. This should be considered for most, if not all, GIST patients where you are planning on systemic therapy of some sort. The problem is that the mutations are not really strongly associated with prognosis, but they may predict the response to therapy. And the results may influence their treatment, either the need or not need for treatment, or even the dose of the drugs that you use. And GISTs that are KIT negative, PDGFRA negative, should be considered for SDH deficiency, usually with SDH IHC stains. So let's talk about prognostic factors. See, this is really the important stuff when we get into the adjuvant therapy. So there are really three things that we look at: the tumor size, mitotic rate, and then the location within the GI tract. I'm going to show you three cases. First one, it's a stomach GIST more than 10 centimeters with a mitotic index of more than 5 per mitosis per 50 high power fields. The metastatic rate here is more than 80%. Okay, let's change one variable. So this is a stomach GIST more than 10 centimeters with mitotic index of less than 5 mitoses per 50 high power fields. The metastatic rate here is only 11%. So you see these are very different diseases. And then if we look at a small bowel GIST, the large GIST, more than 10 centimeters with a mitotic index of less than 5 centimeters, metastatic rate of more than 50%. So this is essentially the same tumor as you saw in the stomach, but just in a different location. It's much worse. So here are this table. I have a few busy tables. I won't walk through them in detail, but I just wanted to highlight a few things. So this one here is just looking at the difference between stomach and small bowel cancer. So this is looking at the tumors that have less than 5 mitoses or less per 50 high power fields. And tumors 5 to 10 centimeters, you see that for the stomach tumors, the recurrence risk is about 3 to 4%. For small bowel is 24%. The same thing for the large tumors. You just, what I wanted to show here with this slide is that just moving the GIST from the stomach down to the small bowel makes a huge difference. Same thing with the large tumors. So, or with the highly mitotically active tumors, once they are into the small bowel, the risk of recurrence is much higher. So let's just show 4 graphs here. So these are, this is the recurrence risk based on size. And you can see how nicely everything separates out there. Larger tumors much more likely to recur. So all of these curves are really nice. What about mitotic count? Look at those curves. Everything like splits out super nicely here. So at the top you see the low proliferative rate. They do really well. And at the bottom, at the blue line, you see the high proliferative tumors, and they do really poorly. So what about location? Stomach, best outcome. Small intestines, worse. Colon or rectum, even worse than that. And then the E-GIST, so these are the extra GI GIST. They do even worse than all of these others. And then one thing that we shouldn't overlook is the importance of tumor rupture. So if the tumor rupture happens at the time of surgery, the risk of recurrence is much higher. And this really the importance of that finding is that these surgeries should be done by someone who's used to operate on GIST, so this should be done by a sarcoma surgeon. So I won't spend much time on the next 2 slides. I just wanted to show you that the association with mutations and risks is very common. So at the top graph there, you see that the top line is the PTGFRA mutated GIST. They tend to do well. At the bottom, you see the KIT mutated GISTs, and they do the worst among these groups. At the bottom curve there, you can actually, let's see, so here you can see that these are the different KIT mutations. So all of a sudden, you've taken this bottom curve here and you split it out in 4 different curves. So this just tells you that there is a fairly complex association even within the KIT mutations and outcome. Okay, this one, I should have tested you on this one. So this is just to show that these are different KIT mutations like substitutions, indels, and the duplications, and even within the KIT mutations, there's a lot of variability there. So moving on to treatment and diagnosis. So imaging, CT or MRI of the abdomen is what really is indicated for most patients. Chest imaging is generally not needed for tumors smaller than 2 centimeters. For larger tumors, you probably should. PET-CT is very useful, but especially if you're planning a neoadjuvant or downstaging therapy or conversion therapy. But PET-CT as it is insufficient as anatomical imaging. If you have PET-MRI, that would work. Those are beautiful, but they give really good anatomic images of the liver and the upper abdomen. But PET-CTs, you've all looked at the CT scans, so they are not that good. So moving on to treatment. So all GISTs more than 2 centimeters or causing symptoms should be resected. And the goal obviously is an R0 resection. But even if there is an R1 resection with a positive margin, it doesn't seem to increase the recurrence risk that much, interestingly. So the capsular rupture it definitely increases the recurrence risk, and that's why you need a surgeon who is used to operate on GIST patients. So as for neoadjuvant therapy, you can definitely use that. These tumors are highly responsive to TKIs, such as Imatinib. And if you have someone where tumor reduction is desired, let's say someone who has a large tumor where surgery would be very morbid, you can actually try treating them up front with neoadjuvant therapy, trying to downstage the tumor and eventually allow for less morbid resection. And here is where genotyping is important. So if these are KIT exon 9 mutated tumors, you should use higher doses of Imatinib, 800 milligrams daily. The PTGFR mutated tumors do respond, but not this particular one, so that's important. And the wild type tumors may or may not respond. Probably most of them probably don't respond that well. And you may need a prolonged neoadjuvant therapy. So this is lifted from the NCCN guidelines. So you have a GIST that needs a neoadjuvant therapy, and you start them on Imatinib. And then what you do here is to assess if you need early assessment. Let's say if it's someone with a large tumor and it's now currently resectable, but you want to try to downstage it, but you don't want to go too far, and then find out 3 or 4 months later that now the tumor has grown and it's unresectable, you can actually consider a PET-CT after 2 to 4 weeks. These tumors can turn cold on a PET within a day or 2. But there's no proven role of really early imaging, but this is actually where an early PET can really help. So adjuvant therapy prolongs recurrence-free survival. This is just a flashback to a previous slide, just formatted a little bit differently. So these are the risk categories of GIST. And just wanted again to highlight the intermediate risk and the high risk. And again, you see tumor size and tumor location as sort of the dominant features here. So these are the things that predict the higher recurrence, as I've spoken about before. And let's then talk about the different adjuvant trials. So the first trial was the ACOSOG trial of Imatinib versus placebo. So this was a 1-to-1 randomization. Patients were treated for 12 months. The GISTs had to be more than 3 centimeters, and the primary endpoint was recurrence-free survival. And so here you can see the RFS. So you can see that the curves actually separate out nicely. This is the RFS at 1 year. So there's a difference here, 98% recurrence-free survival for Imatinib versus 83% for placebo, obviously highly statistically significant. The problem is that the treatment was only for a year, and you see that these survival curves come together again. And these are the overall survival curves, and there is absolutely no difference there. And in this study, genotype was not really associated with recurrence-free survival. So the ERTC did a similar study, so slightly larger study. Again, Imatinib 400 milligrams versus placebo. Here they treated for 24 months. These were high or intermediate risk, going back to my table here 2 or 3 slides ago. And the primary endpoint initially was overall survival, then changed to Imatinib failure-free survival, which is a new endpoint for me. And then secondary endpoints were recurrence-free survival, and relapse-free interval, and a couple of others. So here you see the Imatinib failure-free survival. There was really not much of a difference. Again, recurrence-free survival. If you go back to the previous slide, you see that these RFS curves are identical. So there is definitely an improvement here. So let's see if I may have highlighted that here. These letters are just too small to see, but you can see that these curves separate out nicely, and then they come together again. And the overall survival curves, there is really no difference. But the Imatinib or the IFFS for high-risk patients, there was a difference here for the high-risk patients. And so I think I have it down here. Anyway, let's move on to actually the trial that has really changed the way we treat GISTs in the adjuvant setting. So this is the Scandinavian sarcoma group study that was also performed in Germany. So this was a phase 3 trial, 400 patients randomized to 12 versus 36 months of Imatinib 400 milligrams daily. So here everyone got treated. And the primary endpoint was progression-free survival, and overall survival was a secondary endpoint. This study has been published and has been republished, and there's a lot of really good papers that have come out of this. And these were the tumors that were included. I'm going to spend a little bit more time on this slide here. So, because these were tumors that were NIH high risk, going back to my previous table. So more than 10 centimeters in size, more than 10 mitoses per 50 high power fields. This goes back to my question here. So more than 5 centimeters and more than 5 mitoses per 50 high power fields. And the tumor rupture. So if you look at these curves here. So this is the recurrence-free survival curve, and you can see that there's clearly a difference. But here, unlike the other trials, you can actually see there's a difference in overall survival as well. So this is, here you see you can clearly see that these curves do separate, and the scale is in years. The curves continue to go down. Well, these are overall survival curves. People die of other causes too. And, but you can see that the curves separate out, and they remain separated. This is lifted from an editorial in JCO, I think it was last year. So this, it's an interesting, very interesting slide. So if you look at the different trials, so these different curves are not different patient populations. These are actually on the same trial. These are actually different trials. And if you look at the SSG study, so that's this line here. So this is progression-free survival from the start of therapy. But what I wanted to show you is actually this part of the graph. This is the progression-free survival from completion of therapy. So you can see that these are the different trials, different arms of different trials. Once you stop the treatment, you see how common recurrences are. So one wonders, do you ever cure a GIST, or how often do you do that? So you can see that after you stop the treatment, even after you stop the 3-year Imatinib, you can see that these curves drop pretty sharply here. So recurrences are common and after you discontinue adjuvant therapy. So I think for some patients, maybe for a substantial number of patients, you can actually argue for treating them indefinitely, but that is not approved. Okay, so a few take-home points with adjuvant therapy before we wrap up with advanced therapy. So should be considered for all patients of intermediate and high risk of recurrence. And adjuvant therapy by itself is probably not curative for most patients. This is the standard treatment, Imatinib 400 milligrams daily for 3 years. Higher doses are recommended for exon 9 mutated GISTs, but it's not well supported by data in terms of like prospective studies, but we know that these tumors are not as responsive to Imatinib. And what about those who get it in the neoadjuvant setting? It should be continued, but for how long? Well, at least for 3 years if you add to the preoperative and the postoperative treatment. And then some of them, there's a reason they got neoadjuvant therapy, possibly because they had very large tumors, and for that reason you may even consider extending the therapy. I have a few patients who are still on therapy. And this is actually important, and going back to, I know that I'm sounding like a broken record here, going back to the mutational testing, if you have PTGFRA, the 842V mutation in gastric GIST, they probably don't need adjuvant therapy. They don't even respond to it. Okay, so wrapping up with treatment of advanced or metastatic GISTs. So we know Imatinib works. We've known that for a long time. And these are just 3 trials that have been done in the past. So this all goes back to the early 2000s. And if you look at those 3 different trials, response rates ranging from 45 to 55%, fairly consistent among the 3 trials and different doses. And progression-free survival, they were reported in different ways in different trials. For example, these 56 and 50% numbers was after a median follow-up of 760 days, so it's not a very easy number to grasp. But if you look at the SWOG study, we're looking at progression-free survival of 18 to 20 months for 2 different dosing schedules, and overall survival can be as high as 90% for 1 year, 60, 70% at 2 years. So Imatinib is effective. I think I've shown you that in the previous slide. And what I haven't shown you is the difference in responses in different mutations. So that's what this busy slide is meant to show you here. So again, genotyping does matter. And what I wanted to point out here are the KIT mutations. I know this is all really small. So if you look at the response rates here for exon 9 and exon 11, you see 83% for exon 11, 47 for exon 9 mutations. And you can see for the KIT mutated tumors, there's a pretty consistent good response rate across these 3 studies. What about PTGFRA? So you see that for the exon 12 mutations, really good response rate. If you look at the exon 18 mutations, these are the D842V mutations. You see that they may not respond at all, or they respond much less. And then last year, we have the wild type GISTs, and you can see that the response rates are definitely lower than for KIT mutated GISTs. So this is why genotyping matters, and I think it's good to have this information. So eventually, patients will become refractory to Imatinib. I have to tell you one story, though. So when I was in Arizona, there was a guy who passed through Arizona, and he was moving from the East Coast to the West Coast. So he happened to stay with his daughter in Phoenix, and he was due for a CT scan. Came in, had a CT scan, had metastatic GIST. I'd never seen this guy, had no records whatsoever. So he had these huge liver metastases. And so I was really worried, hey, he's progressing on Imatinib. This guy actually was one of the first one of the first patients to go on an Imatinib trial in the late 90s. He eventually got his initial CT scans from 1999 from New York. No change. They hadn't really shrunk much, but there was no change. And this was in 2013. So these responses can, at times, be incredibly durable. So you can dose escalate for some patients. And so when you do that, you don't really see responses much, but stability can be seen. Some patients have primary resistance. We talked about that. I won't harp on that anymore. But the resistance develops over time, and often due to mutations affecting the Imatinib binding site. So how long to treat? Can we ever stop? I know that we've gone through this with Imatinib in CML, and where there are some thoughts you might stop. I technically am still a hematologist, but I don't treat heme disorders. And so with metastatic GIST, you can't really stop TKIs. So this was a discontinuation study done in France. It's actually a really interesting study. So you can see that here the patients who were on Imatinib with control of their disease were randomized to discontinue or not. So here you can see the progression-free survival. These are those who continued, and they will progress, some of them obviously, because resistance does develop. But these are the ones where Imatinib was discontinued, and see that really within a year, more than half of them had progressed. And the problem is that when you put them back on Imatinib after they progressed, you don't get the same quality response as you did before. It doesn't seem to affect overall survival. And it doesn't seem to increase the resistance when you put them back on. But the take-home point here is that you really shouldn't stop. So what about other TKIs? Going back to that question we just heard. So Sunitinib has been shown to improve time to progression. This was a randomized study. And there was improvement in both time to progression and overall survival. You can see how those curves separate there. and this is approved as second-line therapy. Regorafenib, again, a study where patients refractory to Imatinib were randomized to Regorafenib versus placebo. Huge differences in progression-free survival, and some differences in overall survival. And there are some other TKIs, and no comparative trials, lots of sort of small studies, case reports, case series, and I just listed a few of them, plus one phase 2 trial, the PASAGIST, which looked at pazopanib. And you can sometimes even re-challenge. You've gone through one TKI, you can sort of reuse it and try it again and see if you get the response. So hopefully this has helped with understanding GIST. I know there was a lot of data, a lot of slides, but they should all be in the handout there. And just to summarize, I won't go through all of these summary points here, but they will all be on your slides. So thank you very much.